Welcome to episode 1 of the TBN Together 7 Things You Need to Know About Pressure Ulcer Prevention. Now I'm going to hand you over to Sarah and Carol, who are going to discuss risk assessment. Carol is the lead tissue viability nurse at Cambridge University Hospitals and is also an associate lecturer at Anglia Ruskin University in the east of England. Sarah Masterson is a clinical nurse specialist in Imperial College NHS Trust in London. Over to you, ladies.
Thank you, Jenny. The aim of today's session is to explore what risk assessment is, how and when to assess, review common risk factors to help you be effective in identifying someone who could be at risk.
This session is for anybody caring for someone who might be at risk of pressure ulcers. This could be a carer, a nurse, an allied health professional, or even a member of family. Anybody who thinks they might be at risk of pressure ulcers might also find this session useful. So you might be a patient in the community at home having healthcare professional visits, or you might be in hospital, or you might just be finding it more difficult to move around or check your skin and not be under any healthcare professionals just yet. So who is at risk?
Any person receiving care from a healthcare professional, care agency, or who are just managing in their own home could be at risk. The National Institute of Clinical Excellence, NICE, their guidelines say that any person receiving care from a healthcare professional should be being assessed. But as anyone can be at risk, assessment could be undertaken by anyone involved in their care, including family or even self-assessment. Anyone who knows that person well, sometimes a carer or family member, may be the first one to spot small changes in that person's condition that could be putting them at higher risk. It's therefore important for them to know when to call for help from another healthcare professional. So, when should we do this?
Again, there is formal guidance that says healthcare professionals should assess people at their first encounter. So this means within 6 hours of arriving in hospital or a care home, or the first time a healthcare professional visits somebody in their own home. Reassessment should also happen if a person's circumstances change. For example, if they become unwell, or they have surgery, or if they transfer from one environment to another. But assessment can happen at any time. A family member, a carer, or even the person themselves can consider their risk factors at any opportunity. This might be when a carer is helping with a wash, or a therapist or family member notices a difference in mobility or a change in condition. So this could be during a professional visit, or even when somebody's popping in for a cuppa or doing the shopping.
Pressure ulcer risk assessment is a way of identifying a person who is at higher risk of pressure damage than someone else, and it's considered to be the first step in pressure ulcer prevention. It should be part of a holistic assessment during the first encounter with the healthcare services, and it should be used as a basis for planning, implementing and evaluating your pressure ulcer prevention care. But do we always need to use a tool?
No, there are lots of ways to assess. The NICE guidelines do suggest that we use a validated tool because it means that we're all assessing in the same way and interpreting those results. And some tools can help us to guide our care planning. But you can also use your own experience and knowledge to informally assess. This is known as clinical judgment. But in order to do this, you need to have good knowledge of what the risk factors are. So what risk factors should we be looking for?
Risk factors are grouped into intrinsic and extrinsic. Intrinsic meaning patient factors and extrinsic meaning external factors. And we're going to discuss some of these examples.
So intrinsic factors include poor nutrition and hydration. This leads to reduced skin strength and elasticity, which in turn reduces the ability to heal. Someone who's very underweight might have more prominent bony areas, whereas someone who's overweight will have more fatty tissue that has a poorer blood supply and will affect their ability to heal. Reduced mobility results in pressure over a particular area. Surgery, trauma, or sedation might affect somebody's ability to move themselves. A woman in labour or someone with a disability or after a stroke may also have difficulty in moving and changing their position to relieve their pressure. We know that there are increased risk factors for people at either end of the age range, the very elderly and the very young, but anybody can be at risk of pressure ulcers. We know that older people and the very young can have thinner skin, but other age groups can have any of the other risk factors.
Cognitive impairment affects the person's ability to be able to make reasoned decisions. They may not understand the need for repositioning, eating a good diet, or looking after their skin. Or it may be that they're unable to communicate with others about the discomfort from pressure. Think of a child or someone with learning disabilities. They may not be able to express to you that they're in pain. Look for some non-verbal signs such as grimacing or flinching. Neurological disorders and sensory impairments mean that someone may not be able to feel discomfort or realise that there's a need to change position. For example, someone who's had a stroke, diabetic neuropathy, or someone who's got an epidural for analgesia, for example, a labouring mum. They may not feel areas of their body to know when to move. And poor circulation. It means that the skin is less able to cope with the periods of pressure due to the reduced blood flow. In turn, this means poor healing and, if any, pressure ulcers should develop.
Incontinence is the condition that causes the external factor of moisture on the skin. Any moisture will weaken the skin cells and increase the risk of breakdown. If someone has broken skin, this can cause an increased risk for infection. Infection can impact people in a number of ways. They may become more lethargic or less active, and high temperature will cause sweating, adding more moisture to the skin, and existing wounds can deteriorate. We also know that certain medications, such as steroids or chemotherapy, can weaken the skin. Drugs such as vasopressors and inotropes, which are used in critical care, cause vasoconstriction, which reduces the blood flow, and that makes the skin more risk of developing pressure damage.
Prolonged pressure restricts blood flow to an area of skin, depriving it of oxygen. This may mean that someone does not move enough or change position for a period of time. They may well have a device pressing onto the area of their skin, for example, a plaster cast, a splint, oxygen mask, or even a pair of glasses or hearing aid could cause pressure.
Shearing happens alongside pressure when there is a force distorting the tissues. For example, when somebody slides down in a bed or chair, or if a mum in labour is pushing down on the surface. It could also be caused when a person has been moved in an unsafe way without using the appropriate sliding sheets or hoists. So what tools do we have to help us assess risk?
Clinical judgment can be used, and this is sometimes known as the nurse's instinct. And this is where an experienced nurse is able to use their clinical knowledge of risk factors to identify the person that may be at risk of pressure damage. This can be a quicker assessment and prompts early intervention for pressure ulcer prevention. It can allow for individualised assessment based on observation and clinical knowledge. It can also be performed by anybody at any time. It's considered to be an informal measurement, and it can be difficult to validate or replicate. However, if you use a validated risk assessment tool, the assessment can be replicated and it doesn't rely on the assessor's experience. Some tools have been assessed and validated for specific patient groups, and therefore one tool may not fit all. For example, a tool that's designed for children may not pick up the factors for an adult and vice versa. And we know that there's some 50 tools in use today. But there's little evidence to say that one risk assessment tool is any better than the other, or indeed that it's better than clinical judgment. NICE, however, recommend that we should use a recommended tool, but it shouldn't replace our clinical judgment. In some areas, pre-screening tools are used to help filter out those patients that aren't at risk, but prompting further assessment of those that are identified as having key risk factors. But what happens if you don't assess?
then you're not identifying someone who's at risk and you're not implementing the care they potentially need. Without preventative care, their risk for pressure ulcers will increase. And with that, they're at an increased risk of infection, hospital admission, poor quality of life, or even death. If you're a registered healthcare professional, you're also risking your registration and risking the potential of litigation and safeguarding investigations for your organisation.
What happens if your patient's not concordant or won't allow assessment?
It's really important that we try and explore why. They may have had a poor experience previously, or they may be scared of the outcome of an assessment. You may need to consider things like a mental capacity assessment, best interest decisions, or even deprivation of liberties or advocacy interventions.
What if you identify a safeguarding concern during your assessment?
Then escalate. Follow your local safeguarding policy, but most importantly, make sure your patient is safe.
And what if you're not sure or you need help?
Ask your colleagues. 2 heads are better than 1 sometimes when you're doing an assessment. Involve the multidisciplinary team. Your physios or OT may have a good understanding of a person's mobility issues. The medical team or the GP will be able to review medications. Think about utilising your specialist teams around you for the management of long-term conditions. Consider using your moving and handling team or call your tissue viability nurse. Remember, assess. Anyone can assess, anytime, if they have the knowledge of risk factors. A formal risk assessment tool should be used by a healthcare professional and documented. Reassessment is really important to capture any changes in condition and inform any updates needed for the care plan.
Remember, act. When you've done your risk assessment, it's really important that you act upon it. Risk assessment is only one aspect of pressure ulcer prevention. Put a care plan in place and implement it. Look out for the next TVN Together presentation on skin inspection by Siobhan and Elaine, which will be exploring these things in more detail.
Thank you both for an informative session on the art of pressure ulcer risk assessment. Now, you're absolutely right. There's so many different tools out there, and there's also key differences in how quickly we need to do these risk assessments and also how frequently. I would advise looking at your local policies and local guidelines for this information. Now, join us next week for episode 2, where Siobhan and Elaine will be talking about skin inspection. You can find episode 2 on the TVN Together YouTube channel. And also, keep your eyes peeled for our date for our upcoming Facebook Live, where you have the opportunity to ask TVN Together your questions around pressure ulcer prevention. See you next week.